and good morning. My name is Dr. Carlos Dumlao II from the Department of Surgery, and I'm here to discuss acute urinary retention, or AUR. So, AUR is the inability to pass urine. It is the most common urologic emergency. In men, the most common cause is BPE. In females, AUR is very rare. So, AUR increases over with age, more frequently in men over the age of 60. AUR also has a female to male incidence ratio of 1 is to 13. So etiologies or causes include outflow obstruction caused by enlarged prostate, urethral strictures, prostate or bladder cancers, phimosis or paraphimosis, including urolithiasis. Other causes include neurologic impairment such as spinal cord trauma, demyelinating diseases, diabetic cystopathy, and even stroke can cause AUR. Inefficient detrusor muscle can cause overdistension of the bladder. And medications such as anticholinergics or opioids can cause decreased bladder sensation and decreased bladder contractility. Urinary tract infections can cause inflammation, swelling, and edema of the urinary tract. And pelvic trauma can cause mechanical disruption in the patient's urethra. For the clinical presentation of AUR, so patient usually presents with the inability to pass urine, and they're usually associated with lower abdominal or suprapubic discomfort. In the affected patients are often restless and may appear in considerable distress. History taking should include the evaluation for lower urinary tract symptoms, prostate diseases, pelvic or prostate surgery, radiation or trauma, hematuria, and dysuria. They should also include the history for fever, low back pain, neurologic symptoms, and a complete list of medications, if any. Physical examination should include the lower abdominal palpation or suprapubic palpation, and upon palpation, usually this provokes discomfort in the patient. So, acute management of AUR includes the insertion of urethral catheter or a suprapubic tap or aspiration. So, the materials needed for catheterization are the following: sterile gloves, drapes, antiseptic solution, sponges, lubricant gel, a catheter, syringe, sterile water or saline solution, and the urinary bag. So the patient is placed in a supine position and the lower extremities are frog-legged to expose the periurethral area. The proper wearing of sterile gloves are done, and the inspection of catheter materials are done prior to insertion. So the drapes are placed in the periurethral region. Okay, so for females, the non-dominant hand is used to spread the labia, while the dominant hand is used to clean the periurethral area and insert the catheter. So in males, the non-dominant hand is used to grasp the penis and traction is applied towards the ceiling, straightening the urethra for the passage of the catheter. So the catheter is inserted up to the hub. Okay, and the urine outflow is first inspected prior to the inflation of the balloon. Then after the inflation of the balloon, the catheter is attached to the drainage bag or the urine bag. So absolute contraindications for catheter insertion includes the presence of a urethral injury, which are usually associated with pelvic trauma. Relative contraindications include the urethral strictures or a recent urinary tract surgery. In patients where there is difficult catheter insertion or failed catheter insertion, a suprapubic tap or aspiration may be done. So in the patient with the fully distended and palpable urinary bladder, the area for puncture is cleansed using antiseptic solution. And the large bore catheter, usually a French 16 or 18 catheter, IV catheter, is inserted at a perpendicular angle, preferably a 60 to 90 degrees. Two finger breadths above the pubic symphysis is done. So upon aspiration of urine, the needle is pulled while the catheter or the cannula is maintained. And then the catheter is hooked to an IV tubing, draining into a sterile container. So this is a diagram showing the angulation of the proper insertion of the suprapubic tap or aspiration. So this is a short video showing us the proper insertion for catheterization in female and male patients.
This video demonstrates the proper technique for the insertion of a Foley catheter into a female patient. Begin by opening up the catheter kit onto the tray. Apply the gloves included in the kit in sterile fashion. The small tray is removed from the larger box. The catheter balloon should be tested with the included saline. The lubricant jelly is emptied into the small tray, and the tip of the catheter is well lubricated. Empty the betadine onto each of the cotton balls. Place the pre-cut drape over the vagina. For a right-handed individual, the left hand is used to spread apart the labia, and the right hand is used for performing the procedure. The urethral orifice is prepped using the cotton balls covered with betadine. At least 3 cotton balls should be used. The well-lubricated catheter is then inserted into the urethra. The entire catheter should be inserted, and urine should be seen before the balloon is inflated. Once the balloon is inflated, the catheter can be pulled back to the bladder neck. The catheter tubing can now be taped to the patient's thigh to prevent any tension on the catheter.
So the next video shows us the proper technique, the insertion of catheter in male patients.
This video demonstrates the proper technique for the insertion of a Foley catheter into a male patient. Begin by opening the catheter kit onto the tray. Apply the gloves included in the kit in sterile fashion. The small tray is removed from the larger box. The catheter balloon should be tested with the included saline. The lubricant jelly is emptied into the small tray, and the tip of the catheter is well lubricated. Empty the betadine onto each of the cotton balls. The pre-cut drape is placed over the penis. For a right-handed individual, the left hand is used to hold the penis, while the right hand performs the procedure. The head of the penis is cleaned with the cotton balls covered in betadine. At least 3 cotton balls should be used. The left hand is no longer considered sterile. Using only the right hand, the catheter is inserted into the urethra. The entire catheter should be inserted before blowing up the balloon, even if urine is seen before. If no urine is seen, even after the catheter is fully inserted, gently apply suprapubic pressure. Once urine is seen in the tubing and the catheter is fully inserted, blow up the balloon and pull the catheter back to the bladder neck. The tubing can now be taped to the patient's leg to ensure that there is no tension on the catheter.
So that's the end of my presentation. Thank you very much for listening to my presentation, and always remember to refer your patients to a trained specialist. Thank you and good day.